All right. So we'll get started. This is your kind of final review lecture. Your final exam is not this Monday, but the next. So I'll post up a study guide. I'll hopefully get it completed after this weekend, and I'll go over some of the test format at the end of this whole talk. But this test or this exam will fall into or will kind of encompass everything that we went over for our elbow through the hand and also axial segments and the lower extremity. So kind of comprehensive everything that we finished with. And I will throw in a little bit of kind of those key concepts we've talked about throughout the entire semester. Think back to muscle actions, analyzing movements, planes, axes, all of those. Also remember, if you haven't completed your lab 15 or 16, 16 is extra credit, so I recommend going through that. But take care of whatever you need to take care of, and I recommend getting those in as soon as you can. If you have questions with lab 15, we can go over those at the end. All right, so let's get started. So we'll start out with our humeral-ulnar joint. Start out talking about our elbow. Let me see if I can figure this out. Okay. Talking about our elbow, we're talking about our humerus and how it articulates with our radius and with our ulna. So this is kind of a dynamic elbow system. We have flexion extension at our humeral-ulnar joint, and then we have at our radial-ulnar joint, we have our pronation and supination. So we'll go through each of the individual muscles, go through a quick review. I'm not going to go into super detail. What I'm really going to focus on are movements, actions that are available at the joint, that are available with the muscle involved, and some of those activities that we will see that incorporate these muscles for those corresponding actions. Let me see how I can. All right. So we're going to start off with Biceps Brachii. Biceps Brachii is our prime mover for elbow flexion. It crosses all three joints all the way from the shoulder. Crosses the shoulder, also crosses the humeral-ulnar joint and the radial-ulnar joint, so it can assist with some small shoulder movements, can assist with supination, but is our primary elbow flexor. So think of this as a triarticular joint, and it's dynamic on the anterior aspect of the upper arm or of the humerus. Okay, when we go into brachialis, brachialis is our true elbow flexor. You will need to know kind of basic origins, insertions, but I'm not going to go through them in this lecture. Brachialis is our true elbow flexor. It has no other function. So think of it as our synergist for all elbow flexion movements. And then brachioradialis is our most distal elbow flexor. Its insertion is on the radial styloid process. So this is lateral on the radius. Yeah, lateral on the radius, lateral on the humerus. This is our elbow flexor, especially if we're in a neutral hand position. So we're not in supination, not in pronation. But it can assist in bringing us back to that neutral point along with elbow flexion. So it is a pronator, it is a supinator, but only to that midline point. Right, all three of these muscles make up our elbow flexor complex or elbow flexor group. So any movement where we are concentrically bringing the radius and ulna closer to the humerus in the sagittal plane, we're going to be using this elbow flexor group. Or if we are resisting elbow extension, we're going to be using this elbow flexor group with our three brachial muscles or upper arm muscles. Right, if we move posterior onto our humerus, we have our triceps brachii. Triceps brachii has three heads. It is one muscle, but we have three heads. The long head crosses the shoulder joint. The medial and the short head do not, and they all cross posterior off to the olecranon process posterior over the elbow joint to allow us to perform elbow extension. And the long head can also assist in shoulder extension, adduction, and horizontal abduction. So think of it as a synergist for latissimus dorsi at the shoulder, and also our primary elbow extensor. All right, so now let's move into some of those forearm muscles. We didn't get a whole lot of time to talk about these. Went through a small video lecture. Hopefully you went through that. But we'll go a little deeper into these forearm muscles. The first one is supinator, and as you may assume, it does perform supination. It has its origin on the lateral epicondyle and its insertion on the proximal radius. So it is a supinator. So all supinators, because supination is an external or an outward rotation of the radioulnar joint, this is a posterior oblique muscle. So think of supinator as a posterior radioulnar muscle, and then our pronators are anterior forearm muscles or anterior radioulnar muscles. Right? So supinator performs supination. It also has some synergistic actions for elbow extension, but we're going to focus on its primary forearm movement. If we move into our pronator group, which are antagonists to supinator, they perform the opposite movement. Pronator Quadratus is our distal pronator. Okay, so Pronator Quadratus is distal at the distal radioulnar joint to move that distal joint into pronation. Okay, it works synergistically with Pronator teres, which Pronator teres is our more proximal radioulnar joint muscle, and it also crosses the elbow and can assist in elbow flexion. But this is an anterior oblique muscle crossing the radioulnar joint here, and it will bring the radius inward or into pronation. Okay, so it's our primary pronator. Pronator Quadratus is our synergist, and they work together to pronate both the proximal and distal radioulnar joints. All right, now let's move down into our hand and our wrist. Okay, so we're going to go through our radiocarpal or our wrist joint, metacarpophalangeal, and interphalangeal joints. So we'll start off with some of our intrinsic hand muscles. We're not going to focus on these. These are things like abductor pollicis brevis, other muscles that allow us to move or oppose opposition across the hand. We're not going to focus on these muscles, but we need to know that there are intrinsic muscles or muscles that have their origin on the carpals and their insertion on the digit that they move. Okay, these are most often for that grasping action. If we look at these intrinsic hand muscles, okay, they're all focused, like opponent's pollicis causes opposition of the pollicis or the thumb. Opponent's digiti minimi can cause opposition of our fifth digit or smallest digit. And all of the abductors and adductors allow us to really bring both edge, the medial and lateral edge of the hand, further and closer to each other. Okay, so moving on to our extrinsic hand muscles, these have origins more proximal, most often on the humerus. These extrinsic hand muscles will, in most cases, they do cross onto interphalangeal joints. In some cases, they don't. Some cases, they only move the radiocarpal joint. Okay. The great part about these extrinsic hand muscles, we know that their origin is on the humerus and their insertion is on the digit that they move. And in most cases, the name of the muscle explains where it is and what it performs. So all of these, as you can see here, are extensors. Extensors cause extension. So extensor carpi radialis brevis is a small muscle that extends the carpal joint or the radiocarpal joint on the radial side. So think of radius, radiocarpal, so it causes our deviation towards the radius and extension. Okay, we can go through each one individually. These extensor carpi radialis longus is a longer muscle that performs extension of the carpus or extension of the wrist joint on the radial side. Extensor carpi ulnaris, ulnar side. Extensor digiti minimi extends the smallest digit. Extensor digitorum extends our 4 primary digits. Extensor indicus for our index finger, our second digit. Extensor pollicis, longus, and brevis. So we can really deduce, now that we've gone through more muscles, more movements, more actions, we understand what they perform and where they're located. All right, so let's keep going through here. If we move to some of the anterior extrinsic hand muscles, these are our flexor groups. These have a medial origin on the humerus. So extensors are lateral on the humerus. Our anterior or flexor group is medial on the humerus. And then they have their insertion on their digit that they are moving. So or flexor digitorum has insertions on each of the digits. So we can go through each of these similar to how you went through the extensors. We could go through all of our flexors. Flexor carpi radialis causes flexion of the radiocarpal joint on the radial side, so it will assist in radial deviation. Okay, we can go through flexor digitorum, flexor digiti. Profundus means that it is larger and it is often more superficial. And then flexor digitorum superficialis is the most superficial, and so on. When we look at palmaris longus is not capable of moving the digits. It only performs radiocarpal flexion. Okay, so it can also assist in some weak elbow flexion because it does cross anterior over the humeral-ulnar joint. All right, now let's move quickly into the axial segments, looking at our skull down through our spinal column into the pelvis. We'll also look at each of those, some of those connective tissues that allow transmission of force there. If we look at the movements of the axial segments, we have movement in all 3 planes. And we also are going to talk a little bit about those pelvic tilts if you don't fully understand those pelvic tilts yet. We'll start off with rectus abdominis. Rectus abdominis has its origin on the pubic symphysis and insertion on the costae, so it moves the pelvis towards the ribs or the ribs towards the pelvis anteriorly. So primary function, trunk flexion or lumbar flexion. A posterior pelvic tilt, which is when the pubis moves towards the ribs. So think trying to do turtle butt, trying to tuck your butt underneath, like if you're a dog trying to hide your tail. That's your posterior pelvic tilt. And then it can also work unilaterally to perform some lateral flexion and to assist in some rotation. If we look at external oblique, remember this is our contralateral rotator. So it brings the ribs towards the opposite side pelvis, okay, causing that opposite side rotation. And then it also is the prime mover for lateral flexion on the same side. It causes lateral flexion on the same side, resists contralateral lateral flexion. Okay, with internal oblique works underneath. Internal oblique is underneath external oblique. The right external oblique will work with left internal oblique to cause left rotation. So internal oblique is a same side rotator. So external oblique opposite side, internal oblique same side rotator. And then it also works as a synergist for external oblique on those lateral flexions, and then it can work with external oblique as a synergist for trunk flexion with rectus abdominis. If we look at transverse abdominis, this isn't really a prime mover for segment motion. However, it does cause compression and spinal stability. Because we only have 5 lumbar bones, and none of them are really connected with any kind of stability like we have our costae for the thoracic spine. So creating intra-abdominal pressure can allow for greater stability at a less stable grouping of joints. If we look at Quadratus Lumborum, this is kind of working posterior on the trunk. Quadratus Lumborum is a extensor when working bilaterally. It is a weak extensor. It's not ever going to be the prime mover. If it is a prime mover for lumbar extension, there's probably a problem with your erector muscles. And then it causes unilateral lateral flexion. So it will allow you to bend to the side, but it's more often used to resist contralateral lateral flexion. So when we walk, when we stand, especially on one leg, it will resist that lateral movement. Okay, all of these core muscles, all of these trunk muscles, all of these axial muscles are primarily there for stability. They are not primarily there to cause large amounts of motion. Just reiterate that. When we look at the erector group, so we're going to keep the erector group as an entire group. We're not going to go into any specific individual muscles. We'll just call them our erector spinae group. They have their origin along the vertebrae, all the way up to the skull from the sacrum. Okay. They work as extensors for our lumbar spine and thoracic spine, and they primarily help us stay upright when we are standing, sitting, and walking. So if you contract your erector spinae, it puts you into that nice stable posture. If you cause some hyperextension, you're going to also use that erector spinae. And it can also assist in same side rotation and same side lateral flexion. So think of it as our internal oblique functions, just posterior to the body. So they have same functions as internal oblique, but opposite for flexion extension or opposite for sagittal plane movements. The diaphragm, now we're moving into our breathing muscles. Diaphragm allows us to inhale when contracted, and when we relax the diaphragm, it causes exhalation. This is where we should cause most of our breath. So if we're often in a closed off posture, or we're in a hunched posture, it's difficult to contract your diaphragm. So if you try to take a nice deep breath, trying to push your belly button away from you, okay, push your navel away, it's going to be very difficult if we're in this closed off position. We have a small thorax. If we open up, it's easier for us to move our diaphragm, allow us to take larger breaths, both for inhalation and longer breaths for exhalation. Now, when we start looking at our intercostal muscles, these are what we see most breath, that is kind of shoulder breathing, okay, or chest breathing. They don't allow as much change in intrathoracic pressure, so they can't allow you to create as large of breaths. But if we work together, they are also very fast to contract compared to our diaphragm. So we can use them for both forced inhalation and forced exhalation. So those internal intercostals will compress the thoracic cavity. So when you cough or when you forcibly exhale, you will contract the internal intercostals to push more air out or create more pressure within your thoracic cavity. The external intercostals will allow us to take deep breaths or deeper breaths in, especially when combined with diaphragmatic breathing. So this allows more space. When we're exercising, the fitness of these muscles does play a role. If we have low levels of endurance in our intercostal muscles, we'll often feel fatigue from our respiratory system when we're trying to exercise, especially if we're at altitude. It's very difficult for us to create more pressure at altitude, so you may overly fatigue these muscles sooner. So we use them more during exercise. We don't want to use them as our regular respiratory muscles. That's what our diaphragm is for. Now, if we move up to the thoracic vertebrae, we're just going to look at our Splenius group. I'm just going to name them or call them our Splenius group. They perform extension of the cervical spine and same side rotation. Okay, so think of these as our extensors for the neck. And then sternocleidomastoid, think of this as our opposite side rotator for the neck and our flexor. If we are in a more extended position, it can cause more hyperextension or assist in hyperextension by pulling the mastoid process anterior, causing the cranium to move more posterior. But think of it more as our opposite side rotator and our flexor for our cervical spine. We also have other flexors, but these are the only ones we'll go through for this class. So now we'll move down and take a quick break. If you're watching at home or if you're watching the recording, just take a pause, go back to your notes. I'll pause right now. Does anyone have any dying questions right now? So now we're moving into our lower extremity. Okay, as we move into the lower extremity, we're focusing on the hip joint or the iliofemoral joint, the tibiofemoral joint, the knee joint, tibiotalar, subtalar, and our interphalangeal and metatarsophalangeal joints. I will stop to say there is some rotation that occurs at the knee. The hamstrings help to stabilize and resist it, but as a knee flexion occurs, there is natural rotation of the tibia. Excessive rotation of the tibia can be a problem, especially during high loading events. And if we can't resist that movement, that's where hamstring strength and control play a huge role in knee joint health. All right, so moving down to our tibiotalar joint, think of this as our sagittal plane ankle joint, subtalar joint, frontal plane ankle joint. So they make up the ankle joint complex. Tibiotalar is where we have plantar flexion and dorsiflexion, and the subtalar joint is where we have inversion and eversion. And then as we move down, there are intertarsal movements. They're gliding joints, but we're not going to focus there. Those joints allow us to absorb more force. The more joints that we have distributing forces, especially when we land, when we're running and walking, the better we can distribute those forces and absorb those forces. So this very dynamic foot is extremely important for us to stay healthy. If we have a very stiff foot, or if we have lack of control, or if we're constantly making contact with our heel and not allowing the foot to move naturally, which often happens when we have shoes on all the time, we can see some issues there. All right. We talked a little bit about anterior and posterior pelvic tilts in the trunk section. Anterior pelvic tilt is like you are tipping a bowl out in front of you. So I'll pull up my little video right here, if you can see me. If you take your pelvis, the anterior pelvis is here where my fingers are, the sacrum is where my thumbs are. If I dip my pelvis forward, or think about it as sticking your rear end out, that is an anterior pelvic tilt. If I take my pubic symphysis, take the front of my pelvis and tuck it towards my abdomen, or think going into turtle butt, or if you're kind of flexing the lumbar spine at the same time, that's our posterior pelvic tilt. If we're looking at our lateral rotations, if we're looking at those rotations, think about us as if we are driving a car behind our pelvis. So if we go to the right, a tip to the right. If you go to the left, tip to the left. So a right lateral pelvic tilt will take the top of the left iliac crest towards the midline. A left lateral pelvic tilt will take the top of the right iliac crest towards the midline. If we look at the transverse rotations, think of us as having a bus steering wheel right in the middle. If we turn that steering wheel to the right, so turning our pubic symphysis to the right, we're going to have a right transverse rotation, and then the opposite side, left transverse rotation. Anterior and posterior pelvic tilts are linked with, an anterior pelvic tilt is linked with hip flexion or iliofemoral flexion and lumbar extension, because we're just looking at how the pelvis moves rather than looking at how individual joints are moving. A posterior pelvic tilt is linked with hip extension and lumbar flexion. Okay, so lumbar flexion with hip extension gives us that posterior pelvic tilt, because this is just looking at how the pelvis is moving. With our lateral rotations, these are linked with abduction and adduction, and the rotations are mixed with internal and external rotation. So think of this as how the hip moves causes the pelvis itself to move in space. We can go through further questions in that after. So let's start through our hip joint muscles. Gluteus Maximus, which has its origin here on the sacrum and ilium, and an insertion on the greater trochanter and also on the fascia lata. This is our primary hip extensor and external rotator. Okay, so it causes hip extension. It's our primary hip extensor and our primary external rotator. It does help with horizontal abduction, but its primary function is hip extension. If we look at gluteus medius and minimus, these have origin a little bit more anterior. It does allow some synergistic movements for flexion and extension, but we're not going to focus more there. We're going to focus on its lateral movements. Because the gluteus medius and minimus are frontal plane hip stabilizers, okay, so think of them as the muscles that stop you from letting your hip fall as you walk or as you run. So open chain, or with our leg open to the air, we will perform abduction. If we're closed chain, so that foot's on the ground, it's going to perform a same side lateral pelvic tilt, or resist an opposite side lateral pelvic tilt. Okay, so think about how the pelvis would move if the femur stayed still. Okay, if we look into iliopsoas, this is a grouping of muscles, both iliacus and psoas major. They share an insertion point here on the lesser trochanter, which is posterior and medial on the femur. This allows us to perform hip flexion, outward rotation, and can pull the pelvis anteriorly. Okay, so it can cause an anterior pelvic tilt. So remember that hip flexion and anterior pelvic tilt go together. Any kind of dysfunction or weakness in the iliopsoas can cause stiffness, which will often pull the lumbar spine more anterior, pull the pelvis more anterior, and can lead to back pain. Okay, especially from constant sitting. If you've been sitting a lot since this break, like I have working on the computer, you probably have some tightness in iliopsoas because that muscle has been constantly shortened. And it takes some time to perform more hip extension stretches to stretch this anterior hip flexor. Right, if we look at some of the other hip flexors, TFL and sartorius, think of these as our small or our synergistic hip flexors. Primarily TFL because it does perform inward rotation. So that is our internal rotation at the hip. We don't have very many internal hip rotators. So TFL helps to stabilize against the large external rotators like Gluteus Maximus. Adductor Magnus, think of this as kind of like our extra hamstring. So it performs adduction and assists with hip extension. It also performs a couple, or assists in some lateral rotations. But the main focus for Adductor Magnus for this course is adduction, primary adductor, and primary hip, or a secondary hip extensor, because it does cross the hip joint posteriorly. It can assist in hip flexion or hip extension, especially when we're in a flexed position. And it does only cross the hip joint. It doesn't cross the knee joint like our hamstring muscles. The rest of our adductors are synergistic hip flexors. So think of Adductor Magnus, posterior extensor. All of the rest of our adductors, because they have this anterior origin on the pubis rather than on the ischium like our Adductor Magnus, they're going to perform flexion-based movements and hip adduction. So think of this as our adductor group: adductor longus, brevis, pectineus, and gracilis. They work synergistically with each other, and Adductor Magnus for adduction activities. If we look at the deep outward rotators, we think of this as kind of our rotator cuff for the hip. The key here is that they are outward rotators and joint stabilizers. So they're all posterior and have posterior insertions on the greater trochanter. Piriformis especially is one of the ones you may hear if you go further into maybe rehabilitation settings. Piriformis is often overworked, overused, because think of it as like supraspinatus for our shoulder. There's piriformis there because it does have this stabilization component, and it's not as posterior as our other outward rotators. Right. The last hip flexor we'll go through is rectus femoris. Rectus femoris crosses both the hip and knee joint, so it's biarticular. It will work as a synergist for iliopsoas for hip flexion activities, especially if the leg is in extension. If the leg's in flexion, it's less optimal for rectus femoris because it does lengthen the muscle. And it does assist in knee extension with the vastus group. Vastus lateralis is our primary knee extensor. So out of the four, vastus lateralis is the strongest. And vastus medialis is primarily there to stabilize the lateral movements that come from vastus lateralis because each pull at an angle. And think of vastus lateralis as kind of like 70% of the work, vastus medialis 20–30% of the work for knee extension. When it comes to the hamstring group, these are both hip extensors and knee flexors. So biceps femoris is our lateral hamstring. Semimembranosus and tendinosus are our medial hamstring muscles. As you can see, they have both, think of like the medial hamstrings as medial or insertions, lateral hamstring, lateral origin, and lateral insertion, and so it's lateral to all. But they cross the hip joint and the knee joint so they can assist in hip extension, especially if the knee is also in extension. If the knee is in flexion, it limits hamstring's ability to extend the hip. And it's primarily a knee flexor, especially if we're in a hip extended position. If we're in a more hip flexed position, it lengthens the hamstring muscles, makes it more difficult to perform knee flexion from the hamstring group. Okay, and then both their insertion points allow them to stabilize transverse plane knee rotation, which only occurs during knee flexion, not during an extended knee position. All right, moving more distally to gastrocnemius. Gastrocnemius is also a knee flexor. So think of it as our knee flexor if we're in a dorsiflex position. So if we dorsiflex the foot or dorsiflex the ankle, we can use gastrocnemius as a synergist for knee flexion. So think of it as kind of our distal knee flexor. It's also a plantar flexor if we are in knee extension. So it's an extremely powerful muscle. So things like running, jumping, sprinting, gastrocnemius is a huge contributor, but the knee has to extend first for gastrocnemius to really contribute to plantar flexion. Okay, soleus is deep to gastrocnemius and is a true plantar flexor. So a true plantar flexor, it's going to function most often while we are walking. It'll help with other things like jumping, running, but while we walk to propel our limb forward, propel our body forward, we are using soleus primarily. And because of that, because it's used in most kind of low-level activities, it is mostly tendinous from our Achilles tendon, and it is primarily made of more slow twitch muscle fibers. So think of gastrocnemius as very fast twitch, soleus slow twitch. Okay. If we move anterior over the ankle joint, we have tibialis anterior. Okay, think of this as our dorsiflexor and inverter. Okay, so it crosses anterior to our ankle joint or our tibio-talar joint, and then medial to our subtalar joint, so it will cause inversion. Our peroneus group, think of this as our everter group. So we have our everters and we have tibialis anterior as our inverter. Okay, so they'll work in opposition to each other. The peroneals can assist in plantar flexion and tertius can assist in dorsiflexion, but think of them primarily as everters. And you might experience some trauma in these muscles if you roll your ankle, especially an inversion ankle roll or ankle sprain, where the dorsal surface moves lateral and the plantar surface moves medial. The peroneus group helps to stabilize the ankle in the frontal plane so that you don't roll your ankle or sprain your ankle. So they are very useful muscles, except most often they're undertrained, underused, and often become damaged when we injure the ankle joint. In most jumping and landing sports, we'll see that more often. Okay, tibialis posterior, think of this as kind of an extra plantar flexor. It's really there to help support the arch of the foot, the medial arch of the foot. but it can assist in plantar flexion and inversion. So we have gastrocnemius, soleus, and tibialis posterior working to plantar flex the ankle joint. Tibialis posterior in most people is very deficient, doesn't work very well, isn't controlled very well. I recommend trying to do short foot activities. So if you've ever tried to do a short foot activity, short foots are extremely difficult. Try and set your foot flat on the ground and lift your arch up. So try to bring the metatarsal heads towards the calcaneus. If you can kind of try and do that right now, if you pause it, try and do that on the ground without trying to flex your toes. Just try to lift up the arch of your foot. If you can do it, great, you probably have a functioning tibialis posterior. If you can't, you should probably practice. It is pretty crucial for overall foot health, and we know that foot health contributes to hip and back health. All right, if we look at our flexors, our interphalangeal flexors, flexor digitorum and flexor hallucis longus. Flexor digitorum longus causes flexion of the 4 digits, not the first digit, in the foot. And it can also assist in plantar flexion and inversion. And then flexor hallucis longus is the flexor for your big toe. This muscle is crucial to balance. Okay? Without our big toe, we lose a lot of that kinesthetic somatosensory awareness when we are touching the ground. So when you stand up, as you're walking around, really think about how your big toe is interacting with the ground, or your hallucis is interacting with the ground. It is crucial for our balance. Try to stand and balance with your big toe up in extension. You'll see what I mean. Okay, if we look at those extensors that would cause that extension movement, okay, we have extensor digitorum longus and extensor hallucis longus. Extensor hallucis longus is also an inverter, so it works with tibialis anterior, but think of them as our interphalangeal extensors. Okay, interphalangeal extensors. So if you haven't gotten to your lab 6 and you haven't watched the video on movement analysis, I'll go quickly through movement analysis, where we start looking at movements, not just basic exercises like we have been, looking more at some dynamic movements. The first one that I want to go into is walking. Walking is a commonly studied movement pattern within biomechanics because without walking, we struggle to function in most daily life. So if we look at the phases of walking, we have both a stance and a swing phase. We treat them separately because the muscles function differently and different muscles are functioning to coordinate those phases. So at heel strike and during this loading response, we're really seeing a eccentric action from our extensors, especially our hip extensors, our knee extensors, and we're trying to resist plantar flexion initially and resist dorsiflexion during that loading response. So we're getting a lot of eccentric actions initially into the stance phase. So here's stance phase. During mid stance, we're working and starting to begin the concentric work, where we start to pull the center of mass forward over that stance leg so that we can continue to move forward. During terminal stance, we're using our plantar flexors, knee extensors, and hip extensors to propel our body forward. And then during pre-swing, or kind of terminal stance to pre-swing, we are toeing off and beginning to flex the knee and flex the hip to prepare for our swing phase. During that swing phase, that leg we're focusing on, in this case the right leg, we are performing hip flexion to bring the thigh forward, knee flexion so that we can allow toe clearance, and dorsiflexion so we can allow toe clearance. If we don't perform knee flexion and dorsiflexion, we'll often have this kind of toe drop. This is where you trip and fall. We see this in a lot of people who have neuropathy or lack of control at their distal limb. They're more likely to trip and fall because they can't control the foot, control the ankle during that mid-swing and toe-off phase. And then during terminal swing, we need to slow the leg down so that we can prepare for heel strike again. So as we doing mid-swing, we are flexing the hip, During terminal swing, we are using our hip extensors to eccentrically resist that flexion. So now that the leg has some momentum moving forward, we have to resist and control the limb. We start to use our knee flexors again to eccentrically resist knee extension so we don't overextend our knee joint, and we begin to use the dorsiflexors to prepare the foot for heel strike. So perform more dorsiflexion to prepare for heel strike, and we go through that phase all over again. We could also go through running. Running is similar, except there is no double leg support. So walking, at some points in time, both feet will be on the ground. Running, we only have one leg on the ground or no legs on the ground. That's what really characterizes running compared to walking. So during this heel contact, we're doing the same thing, especially if we strike with our heel. We're eccentrically using our hip, knee extensors. We're using our dorsiflexors to resist plantar flexion. And then during mid-stance, we are eccentrically resisting the falling of our mass. So we're using our hip extensors, knee extensors, and plantar flexors to stop us from continuing to move towards the ground. From mid-stance to toe-off, we are using our hip extensors, knee extensors, and plantar flexors to push us off the ground. Once we leave the ground, we begin to use that same recycling format that we use for walking, where we perform hip flexion, knee flexion, and dorsiflexion to reposition our leg for the next heel strike. So we bring us into that hip flex position, then we use our extensors and our knee flexors to resist that extension position. So it's kind of creating momentum and then slowing that momentum down so that we can reposition the limb. That's kind of a quick breakdown. That's not a really super in-depth breakdown, but you understand how to really focus at each joint individually throughout and focus on our stance phase and focus on your swing phase individual. All right, let's go through some individual questions. I know that was kind of like a jam-packed, as fast as possible review, but what questions do we have? Don't just wait for other people to have questions. You can put them in the chat if you don't want to turn your audio on or something like that. All right, if you think of one, just please interrupt me as I'm going. Your exam, your final exam is on, let me pull it up, make sure I get the right date. Your final exam is on Monday, May 18th. The exam will be open the entire day. So from the beginning of the day at 12 a.m. all the way to 11:59 p.m. You will have the full available time to complete the exam. So you would have normally an hour and 50 minutes to complete a final exam. You will have that time limit. You'll only have one attempt. So make sure that you have a good connection, make sure everything is set because you do only have one chance. Then we will, or this exam will also be out of 100 points. So it's a little bit more in depth than the rest of your exam, but you also have an extra 35 minutes to complete the exam, and it's all at home and open book and open notes, just not open friend. You should have time. I recommend don't try to search for every single answer in your notes. Try and be as prepared as possible first, and then move into the exam. What else? The exam will consist of a similar format to the other exams, except we'll add in some more overall content. I see there was a question. Can I go over the lab? What part of the lab? The last chart. What's a prime mover during the lunge with the left leg out in front at the tibiofemoral joint? Carson, if you could you put your volume on so I can make sure that I'm understanding your question? So which are you talking about an image in the lab?
Yeah, I was trying to figure out where it was. He was going down, left leg out front, and it was the left tibiofemoral joint. And it asked what the prime mover was. And I was assuming it's knee flexion, but I just didn't know.
Okay. So let me pull up an image of the lunge. Okay, so if we're looking at a lunge here, or this is kind of like a little split squat lunge activity, so let's focus just at the tibiofemoral joint. So if we look from image 1 to image 2, what's the movement?
That'd be knee flexion, right?
Okay, so it's knee flexion at the left knee. So we see knee flexion. Which direction, or where are they going compared to what they're trying to do? Are they trying to go down, or is he trying to resist himself from flexing his knee? Is he causing knee flexion or resisting knee flexion?
Resisting.
Resisting. So what would be the muscle action at the knee joint? What would be the contraction? What'd you say?
Extension.
So we're trying to cause extension. So what would be the muscle action or the contraction type?
Eccentric.
Eccentric. So what is a muscle that causes eccentric flexion or resists knee flexion?
Wouldn't that be the quadriceps femoris?
Yes, because they're the knee extensors. They cause extension and resist flexion. One of the tricks that I'll give you as we go through, if you are watching and if you see it's eccentric, if you rewind it, the prime mover would concentrically reposition that person. So eccentric knee flexion, if you wanted to reposition yourself, you would have to cause concentric knee extension. So it would be your knee extensors working, because the same muscle group resists the opposite movement that it causes.
Are we able to say quadriceps femoris, or do we have to go down to like vastus, lateralis, medialis, and all of that?
Quadriceps femoris is totally fine. No one knee extensor will work on its own. They all work together. Yeah. Yeah. And then another question on the lab for, what is this? The last chart, number 6. See if I can pull that up. Last chart, number 6. So this is a side plank facing right. So a right side plank. If we look at the iliofemoral joint during a side plank, it's similar in the image for the lab. Where'd it go? So here, if we're looking at the iliofemoral joint or the hip joint, it's kind of confusing, especially because we're on the side. It doesn't look like a normal position. I will show you a quick trick that if I stand this person up and I look at where their pelvis is compared to their thigh, I move from an adducted position to an abducted position on the same side. So if you're on your left side, like in this image, that is left hip abduction, performed by your abductors, so gluteus maximus, medius, and minimus. If you're on the right side, it's just the same muscle group on the opposite side. Antagonist for medial arch support. there's no muscle that causes the arch to go down. You could say your everters. So the question was, what is the antagonist for medial arch support? In most cases, the antagonist is just relaxation, gravity. We're not going to have a muscle cause us to go into that position. But if you think about the foot and the arch falling, it also is often accompanied by eversion. So if you contract the everters, it'll often cause the arch to fall also. And tie the vastus lateralis or just the quadriceps group would be the prime mover for eccentric knee flexion. Is the glute medius or minimus prime mover? So gluteus medius is often our prime mover, or gluteus maximus, especially if we're in a more hip flexed position. We'll use gluteus maximus a little bit more, but in most cases, you'll be asked what's the synergist, and minimus or medius are both adequate answers. In most cases, gluteus medius is the prime mover, though. We'll put it there. What other questions do we have?
You said the final exam is out of 100 points?
Yes, 100 points. It's also listed on the syllabus.
Can you go over number 8 on the hip and knee movement analysis chart?
So lab 16?
Yeah.
So this is the extra credit one, right?
Oh wait, no, lab 15 still.
Okay. So which one?
Number 8.
On this?
Yeah.
Okay. So this one's a little easier if I have you in front of me, but I can't. So here's how you're going to do it. You're going to stand up. If you're at any of you at home, you can do this as you stand up, and you're going to take your knees and hips and flex them about 15 degrees. So it's kind of like a little mini squat. Feet parallel, and then you're going to dorsiflex your left ankle. So you're leaving only your heel on the ground and lifting the rest of your foot off the ground. Then you're going to move the right hip in the transverse plane. So this is a key word here, right hip in the transverse plane. You're analyzing the right hip here, or the hip joint here. So that the feet end up 90 degrees to each other while the left heel stays on the ground. So think of this as kind of like a pivot, like if you're trying to squash a bug. You're using your right hip to cause pelvic rotation. So what movement do you think that is? Is your pelvis is your thigh rotating outward or inward?
Would it be outward?
Outward. So that would be what movement?
External rotation?
Absolutely. Yep.
Okay. It just sounds weird reading it and then doing it.
It does sound weird reading it, but once you do it, you can kind of feel what's going on. So that's kind of the purpose behind these ones, to read it, and then hopefully you try to perform the movement. Just like one where we're number 4, this is a hip joint, not a knee joint activity. So stand with the knee extended, then flex the knee to 90 degrees. That only leaves one foot on the ground. Now what are you doing to your hip joint to not fall down? So at home, you can stand up and leave your left foot on the ground and just flex your right knee 90 degrees. What do you have to do to your pelvis to maintain that position? Does anyone have the answer? Come on, don't be shy, try. What's the movement for number 4? At the hip joint. At the left hip joint.
Is it flexion?
So if you only flex the knee and your left leg's on the ground, it would not be flexion because you're not moving in the sagittal plane. Think about your balancing your pelvis. Only flex your knee, it doesn't say anything about flexing your hip. What would be the movement at the left side?
Left side pelvic tilt.
So left side pelvic tilt, what's the hip joint movement though? So what causes a left side pelvic tilt at the hip joint?
Extension?
So extension would cause a posterior pelvic tilt. What causes sideways pelvic tilts? Think about sideways or lateral pelvic tilts. What plane of movement would that be in? Sagittal, frontal, or transverse?
Would it be abduction?
It would be abduction, yep. Because you're trying to stabilize the pelvis as one leg comes off the ground, the pelvis wants to fall down. So we use abduction at the hip to hold that pelvis up. So every time we walk, we have to have that frontal plane stability from our hip abductors like gluteus medius and gluteus minimus. That's why they're so important, because they abduct to keep us stable when we're on one leg. What other questions do we have from lab 15? You should be able to go through these through your notes and listening to the videos. Should be able to go through these, going through the videos and notes. Any questions through our a day at the gym activity? The lower extremity is the bulk of your exam. So if there's any questions with movements, this is the time to really go into those. All right, I'll assume there's no more. And then at our hip and knee movement analysis chart, the last set of movements, we went through 2 of them. Is there any other one that we want to go through or need help?
He said day at the gym 13. That's what someone commented.
I can't see the chat on. It's not allowing me to see it as I view.
So day at the gym, number 13.
Okay. Sorry, I can't see the chat as I'm sharing the screen. Okay, so number 13. So let's get our video going. Or our images going. Number 13. So this is the same movement that we were just talking about with what happens when we take one leg off the ground. So if we see it here, we're taking one foot off the ground. And now we have to abduct the pelvis. This is called a hip hike activity. Lift up or abduct the pelvis. As we're closed chain, the thigh's not going to move because it's affixed to the ground. So the pelvis is what's able to freely move. Some of the help that I like to, or some of the things that help a little bit are to add little lines. So if we think about the leg here, I'll change the color so that we can see. So if we look at the thigh, and then we look at the pelvis from ASIS to ASIS, looking across our pelvis, we're kind of in this neutral position. If I take this same image to here, now my hip is more open, or has a greater angle in the frontal plane. A greater angle in the frontal plane indicates to me that I am performing abduction. Any other ones? Going once, going twice. All right, I'll be holding another one of these optional reviews or little reviews. The next one won't be recorded. I'm just gonna answer questions. So if you have questions from any of your labs or anything off the study guide that I sent you, I recommend go through the study guide before the review meeting so that you have questions, because without questions, it kind of slows the meeting down. I don't want to waste your time on anything like that. And yes, I will be posting, that's a great question. So the question was, is there going to be any posting of old lab keys? I will be posting the old lab keys on Blackboard after all of these have been completed. So after Friday, I'll complete the key, make sure everything's up to date on any changes that I made. And post the keys up so you can correct and go over all of those. Yeah, I don't want you to be studying information that's incorrect. All right, I'll hang out for the next couple minutes. If anyone has any questions that just pop into their head. Otherwise, thanks for showing up. Thanks for the questions. I hope you got something out of this review meeting. Thank you. For knee extension, you just have the quadricep group. There's no other knee extensors. So just those four muscles work together to extend the knee.
Professor Moffat?
Yeah.
Can we go over number 5 on the hip and knee movement analysis chart?
Number 5. So double leg landing from box until hands touch the ground. So imagine you're jumping off of like a curb or a box, and you are landing all the way until your hands touch the ground. What's happening at the tibiofemoral joints or the knee joints?
So my knee's bending. So
that is?
knee flexion.
Yes.
Okay.
Are you causing knee flexion or resisting knee flexion?
Resisting.
So that would be what type of contraction?
Constant or eccentric.
Eccentric knee flexion. So what would be the prime mover? What muscle would resist knee flexion?
Quadriceps.
Quadriceps. Synergist would be any other one of the quadriceps. What would be the antagonist?
Hamstrings.
Hamstrings, and then you can go through origins and insertions.
Okay.
Yep.
Sweet. Thank you.
You're welcome.
At the tibiofemoral joint, what causes internal rotation?
So at the tibiofemoral joint, we often don't cause rotation. We don't often try to, but we can. The medial hamstrings will cause internal rotation. The lateral hamstring, biceps femoris, will cause external rotation at the tibiofemoral joint. And that's only while the knee is flexed. So that can't happen if the knee is in extension. Only if the knee is in flexion, we can get a little bit of tibial rotation.
Okay. Thank you.
You're welcome. Isai asked, is TFL the only hip internal rotator? The only one we really focus on in this class. Gluteus medius, the anterior fibers, can assist in internal rotation, but we'll just focus on TFL for the sake of this class. All right, if that's all the questions, then I'll conclude this meeting.